Great, thank you. That's fine. Okay, next topic is acute appendicitis. Very different from the last topic, very common entity. Maybe this sounds like a boring topic to everybody, but for me, what's exciting about appendicitis is they all look different. It's kind of like, you know, some of what Dr. Sickles was talking about in mammography. The fun of this is that appendicitis has such a broad spectrum of appearance that I think it keeps us alert when we're reading these cases. So, same disclosures, none of them are relevant here. This is the real reason we do so much CT for appendicitis. Before we were routinely doing CT, you see in the solid curves here a very low rate of CT imaging back in the 1990s, and we had a very high rate of negative appendectomies. That is, patients who went to the OR to have their appendix removed and they found a normal appendix, so potentially did not need the surgery. About 20%, a bit higher for women than for men. After the widespread use of CT, here in the 90 to 100% range before their surgery, we saw this rate drop as low as about 2%, meaning that it is very rare these days that a patient goes for an appendectomy and they actually find a normal appendix. When they do, we hear about it. They're very unhappy with us for leading them astray and making them do a surgery that was not necessary. So as a result, most of our surgeons really want to get CT before they operate on a patient. As a result, we've seen a falling threshold for imaging with CT in the emergency department, which means that we're seeing appendicitis much earlier in its course than we used to see it, which also means, a good thing, we're seeing much less complicated appendicitis, perforation and abscess, and we're seeing decreased morbidity and mortality as a result. So I'm going to step through these different areas in this talk, starting with imaging techniques. So what technique should we use? This is a case without oral or intravenous contrast, this with intravenous and oral contrast, this one with intravenous and rectal contrast, and we can clearly see the appendicitis in all of these three cases. So what should we do? Well, all of these combinations in various studies in the literature have been found to have high sensitivity and specificity, so it really comes down to institutional preference, logistics, and philosophy. What we do is we give intravenous contrast for all of these patients. We do a traditional 70-second portal venous phase scan delay, and we do not give oral contrast anymore for appendicitis. We used to, but as part of the move to get patients through the ED faster, we shortened the preparation time for oral contrast to 1 hour from the first sip of contrast. And if you do that, it only reaches the cecum and the appendix maybe a third of the time. So it's really not doing very much good for us. So we've actually eliminated it, and we've never gone back. I do, however, feel strongly that intravenous contrast is very, very helpful, and I'll show you why in a bit. In pregnant patients, we do things a little bit differently. We do ultrasound first, which I have to admit is very low yield because usually the appendix has been elevated by the gravid uterus. It's very hard to find. So at that point, we proceed to MRI, which usually ends the workup. Very, very rarely do we go on to CT. If we do go on to CT, I personally believe in pulling out all of the stops, giving intravenous contrast, oral contrast, and rectal contrast, because the last thing I want to do in a pregnant patient is directly irradiate the fetus twice. I can't remember the last time we did a CT in this scenario, though. We do 5 millimeter axial reconstructions here. We do 3 millimeter coronal and sagittal reformations. The coronals are traditionally the most helpful because the appendix just happens to line up very frequently in the coronal plane. It makes it very easy to visualize a much longer course of the appendix than these short cross sections here. Very helpful for communication. Some strategies for success: always find the appendix, at least in your ED scans. And the way I like to do this is always run the colon from below, come down the ascending colon, find the ileocecal valve, which often contains some fat within the lips of the ileocecal valve, continue south to get to the cecum, and find that appendix there and there. Always report the appendix, particularly on ED cases. The appendix is normal, the appendix is not visualized but no secondary signs, findings highly suspicious for early appendicitis, These are a range of very common phrases that I use in almost all of my reports in the ER. Don't be overly swayed by clinical factors. Sometimes radiologists get a little bit uncertain about their diagnosis if they hear that, oh, the patient has no fever and they have no white count. But a substantial minority of these patients don't have an elevated white count. The location and nature of pain can be quite variable. And to be honest about it, if clinical diagnosis of appendicitis was so good, then we wouldn't need CT. It's very difficult to diagnose a lot of appendicitis cases clinically. So stick to your guns if you see convincing findings of appendicitis. I really encourage everybody, if you're not sure, follow that case and find out what pathology was, because this is the only way to really improve yourself over time. So let's talk now about imaging findings throughout the spectrum of disease. We're all familiar with a number of the direct signs of appendicitis. The appendix can be distended by fluid. People use 6 millimeters a lot, but keep in mind that this is only a rule of thumb. This actually comes from the ultrasound literature in pediatric patients, where with compression, the appendix does not go to a diameter smaller than 6 millimeters. In CT, you can often find a normal appendix that has a larger diameter. It is very rare to find an abnormal appendix that is smaller than this. So this is helpful if the appendix is thin, not as helpful if it's distended. An abnormal appendix typically does not fill with oral or rectal contrast, and generally does not fill with gas, although there are exceptions here. We will look for wall thickening of the appendix. We'll look for wall hyperemia, which is a very helpful sign, but you need intravenous contrast, of course, to see that enhancement pattern. And we'll look for appendiculus. These may or may not be calcified, and these may be incidental. You will often find an appendiculus in a normal appendix waiting for another day and another ED visit. Look as well for cecal base thickening, with the caveat that you won't see this in a distal or tip appendicitis. Sorry, that's cut off down there. Secondary signs, we look for periappendiceal fat stranding, extremely helpful. This can progress in more severe cases to phlegmon or abscess. We want to look for reactive inflammatory findings in adjacent structures. We can see wall thickening in the sigmoid colon, in the small bowel, or in the bladder. We're looking for signs of secondary involvement, either secondary small bowel obstruction or ileus. Occasionally we'll even see hydroureter, because as that ureter exits Gerota's fascia, it's susceptible to inflammation from the appendicitis, and you can see some distension of the ureter. Look for fascial thickening, ascites, peritonitis, reactive lymph nodes. So this is not common to see. This beautifully normal appendix fills all the way through with with gas. This is the CT correlate for that. We have a nice narrow appendix filled with gas here. This is another normal appendix, but it is 11 millimeters. So we can't use that 6 millimeter rule of thumb too severely, particularly if it's filled with gas. The appendix can distend to a larger diameter. This is a clearly abnormal appendix. Here we have a thickened, fluid-filled appendix containing appendiculus. We have associated thickening of the cecal apex. We have surrounding fat stranding. We have a little bit of fascial thickening and maybe even some bladder wall thickening next to this appendicitis. Here's another case. This one is quite fluid-filled. There's a little bit perhaps of hyperemia of the wall. We have a big appendiculus at the origin, and we have a fairly mild amount of surrounding fat stranding, but this is nonetheless acute appendicitis. On the other hand, different case, very different appearance. We have here the dominant feature is marked wall thickening and surrounding fat stranding, with actually very little fluid distending this appendix. So we can see a wide variety of appearance. Here's a patient where we happen to see these calcified appendiculus on the CT projection radiograph. Here it is on CT. There are the appendiculus. Here is the fluid distended hyperemic appendix with some surrounding fat stranding, though it's very difficult because this is a small patient with very little surrounding fat. Here we have a case where we have a portion of the appendix probably visible here, but very hard to distinguish exactly where it is, probably somewhere in here. We see a lot of surrounding fat stranding. We see a lot of fascial thickening here. Here we see that slightly distended ureter from reactive ileus. The last thing I was showing was some reactive mesenteric lymph nodes there. But this one, again, very different appearance from the last two. So signs of complicated appendicitis. First is gangrene. If we see a lot of interluminal gas within a clearly abnormal appendix, we can suggest that this might be a sign of developing gangrenous appendicitis. It's helpful to look for the enhancement pattern in the wall of the appendix, because if we see a gap, we can suggest necrosis, which can very rapidly lead to perforation and abscess if it's not treated quickly. We, of course, look for signs of perforation, including focal discontinuity, extraluminal gas, or an extraluminal appendicolith, and of course we want to look for an adjacent abscess. Here are some examples. This patient has an appendicolith at the origin. Here is the appendix. Here we have it distended by fluid and by gas. On our coronal images, we see similar findings. There's our gas, fat stranding, appendicolith. This may represent early gangrenous appendicitis due to this amount of gas. That is not a normal finding in uncomplicated appendicitis. Here's a slightly more severe case. We have this thickening at the origin of the appendix in the cecum. We have a non-calcified appendicolith here, and we have a lot of gas and fecal-looking material within the lumen of the appendix, a large amount of surrounding fat stranding, reactive thickening of the adjacent sigmoid colon. This is a gangrenous appendicitis. Here we have a very nice cross-sectional image through this portion of this appendicitis. We see this target appearance. We have enhancing mucosa, enhancing serosa, and the muscular layer is low attenuation because of its edema. If we come down a little bit farther, we see that we lose that nice target sign here, and we have a focal discontinuity here in this appendicitis that's showing some signs of early necrosis, though it does not yet appear to have frankly perforated. Here's another case, again, appendicolith at the origin of this appendix, and here we have a lot of surrounding fat stranding. We have gas in the lumen, and we have a small focus of extraluminal gas here, which you can also see coming straight through the defect in the wall. This was a necrotic area that has ruptured, allowing gas to exit outside. So this is early ruptured appendicitis. Here, in a more severe case, we can see a bit of the appendix distended by fluid, hyperemic wall containing gas. It's hard to find most of the appendix down here. There's an appendicolith that may or may not be intraluminal here and here. And most importantly, we see this adjacent collection of fluid with a fluid level within. This is a periappendiceal abscess from perforated appendicitis. Here, an even more severe case where we have a large collection of fluid with an enhancing organized rim, multiple small foci of gas within this pus-filled abscess surrounding the sigmoid colon. And this, it turns out, is the appendix that had ruptured at its tip to create this abscess. Now, there are a variety of variant or atypical presentations of appendicitis. This is a tip appendicitis. You can see the origin here is normal. There's some minimal fat stranding, very minimal, surrounding this appendix. And there's this slightly enhancing hyperemic wall. Very helpful finding only if you give intravenous contrast. Without it, I think it might be very difficult to diagnose this early tip appendicitis. Here's another case. We see in this case that was back when we were still giving oral contrast here. We see a nice contrast-filling appendix here. We're tempted to say that this is normal, but if you keep going, you find an appendicolith in the mid portion of the appendix, which is fluid distended. There's another appendicolith at the tip, and this turned out to be a 22 centimeter long appendix, the first 12 centimeters of which are normal. So we really need to try to follow this all the way to the blind end, because it can otherwise be very difficult to see this. When I did have this case, I immediately went to the Guinness Book of World Records, but I had missed by 4 centimeters. The longest appendix at that time was 26 centimeters. I think we're up to 28 when I checked last week before coming here. Anyways, the appendix can be located in many different places. We can have retrocecal, we can have a left-sided appendix, particularly if we have a mobile cecum or a malrotation. This can be present in hernias or in an inguinal canal. This is a so-called amnion hernia. from an appendicitis within the inguinal canal. This patient presents with groin pain, not the classic symptoms. Here's one that we saw of an appendicitis within a Spigelian hernia. This patient presented with abdominal wall pain from this inflammation in the abdominal wall due to appendicitis. Here's a patient where you can see we have this appendix on a coronal or on a sagittal image coming all the way up next to the gallbladder. This patient presented with symptoms more like cholecystitis, because this retrocecal appendix is coming all the way up and tickling the gallbladder region, right upper quadrant pain. So the location of pain, again, is not a terribly reliable thing for our clinical colleagues to use. Here we have a case where, an uncommon case, where we have this appendicitis obstructed by a cecal adenocarcinoma, causing this perforation and small focal abscess here. So not all appendicitis is caused by appendiculitis or by inherent inflammation causing obstruction of the lumen. We can have other things obstructing the lumen, like this adenocarcinoma. Finally, mimics. There are a wide variety of things in the right lower quadrant or the right side of the abdomen that can mimic a clinical diagnosis of appendicitis. And this is just a brainstorm list of what I thought can easily be confused for appendicitis clinically. And I'll show you just a few. Do I have 5 more minutes? Is that about right? 1? What's that, 4 more minutes? Okay. 14 minutes. Oh, all the time in the world. Great. Okay, I was going fast after the last one. All right, so what do we see here? Well, we see clearly there's either fluid or wall thickening of the gallbladder. Those are very hard to distinguish actually on CT, gallbladder wall thickening or pericholecystic fluid. But either way, we have something abnormal in the gallbladder here. Perhaps if I show you a very narrow window, you can see that there's a non-calcified gallstone in here. This would show up beautifully on dual energy CT, I'll add. Here's the appendix, right up in Morrison's pouch. This could easily have been an appendicitis case, but in fact, as you all can tell, we have truly wall thickening here. We have an impacted gallstone in the neck. This is a cholecystitis case. Here's another case, similar, gallbladder wall thickening or pericholecystic fluid here, but we also see in this case tremendous biliary dilation, intrahepatic biliary dilation, and if we follow the common bile duct, we see that the common bile duct is quite distended. So our job is to find out the source. We continue to follow the common bile duct down, and there we see our common bile duct stone that's creating this biliary dilation and is responsible for this cholecystitis. Moving on here, on these 2 images, what I'm showing you here is a normal appendix. There it is beautifully in cross-section. But if we look at the top of our scan, we have a lot of gastric wall thickening here in this patient with gastritis or peptic disease. Here we have another patient who comes in with right-sided pain. I hope you can see that we have some heterogeneous enhancement within the cortex of the kidney. We also have a little bit of enhancement of the urothelium, both in the collecting system and in the ureter. This is findings of pyelitis and pyelonephritis here, causing right-sided pain that can mimic appendicitis. Here's the nice normal appendix sitting nearby. Here is a case, axial images, coronal images. We see a lot of colonic wall thickening. We see a culprit diverticulum that's inflamed with a lot of surrounding inflammatory fat stranding. This, of course, is a right-sided diverticulitis. I think, at least where we live, most people think of diverticulitis as a left-sided disease, which it certainly is the majority of the time, but we will frequently see ascending or cecal diverticulitis that can very easily mimic appendicitis. Here, however, is the normal appendix. The other thing we can sometimes see is secondary inflammation of the appendix from a diverticulitis or from other adjacent inflammatory findings. But again, very important to distinguish whether the primary source of inflammation is the appendix or something else, because if there's secondary inflammation, often the appendix does not need to be removed. This is a patient who presents with a very abnormal loop of small bowel. We see some contrast making it through. This wall thickening is very high density, and we have a lot of high density engorgement in the associated mesentery. This turned out to be a case of small bowel hemorrhage in a patient who had been anticoagulated a little bit too aggressively. This is one of my favorite cases. Here we see a blind ending structure that ends right here with a little bit of gas that looks like it might be extraluminal. So naturally we think of appendicitis in the right lower quadrant, but this is too big for appendicitis. And if we carefully follow this on our imaging and see where it goes, or in this case create a curved MPR, we see that this comes off as a T-shaped structure from this small bowel loop. This was a Meckel's diverticulitis with inflammation and phlegmon at the tip, right in this region of inflammation. So Meckel's diverticulitis is a fun diagnosis to make if you can do it in the right lower quadrant. Now, if I show you this, we know what this is. This is epiploic appendicitis. Here we have a central globule of fat at the antimesenteric border of the descending colon with a surrounding rim of inflammation and inflammation extending beyond into the adjacent fat. If I show you a case like this, it has a very similar appearance to epiploic appendicitis, but it's a bit larger. It may or may not be directly associated with the colon. Often it's not. There's the normal appendix. This is segmental omental infarction, very typical location for this entity, perhaps on a congenital basis for a portion of the omentum that can either torse or infarct. The reason I show this is because you can also see this down closer to the appendix. Another of my favorite cases here. Here we see some inflammation in the right lower quadrant. So our resident at the time said inflammation down by the cecum. This must be appendicitis. The patient gets put in a wheelchair to go down to the operating room. But if we look closely here, we can see that the appendix here actually loops around. This is the tip, this is the origin of the appendix, and the loop in between, that actually looks pretty good. And the inflammation that we're seeing here is a bit remote from the appendix. And this turns out to be a cecal epiploic appendicitis. So similar to the last cases I showed you, we have a central bit of fat here that has necrosed. We have a surrounding hyperdense rim from our epiploic appendicitis with a very small amount of adjacent fat stranding. And this patient, in fact, did fine after 1 week, only taking some oral anti-inflammatory medication for pain control. So uncommon to see here, but keep in mind the variety of things that can mimic a clinical diagnosis of appendicitis, and don't go down the path of just assuming that everything that looks like inflammation down there truly represents appendicitis. So I've tried to step through a variety of topics here for appendicitis, and perhaps I'm a bit early at this point, but we have some time for questions, and if not, I'll use the time for the case-based talks that come next. Thank you.
Is there any questions from the audience? Well, I will ask one question.
Sure.
How often do you diagnose suspicious early appendicitis? And what are the criteria for early appendicitis, and how accurate is the diagnosis of early appendicitis in your institution, at your institution?
So the question was, how often do we diagnose early appendicitis? You mean the very subtle cases?
Yeah.
It's hard to know because we don't know what we're missing, right? We don't have a true denominator. I would like to think we're diagnosing it frequently. I do know that we are certainly diagnosing appendicitis much earlier than we used to many years ago, based on very subtle inflammation and enhancement of the wall. The interesting question, I think, is what to do with these patients, because there's been a growing trend, particularly in Europe, for some of these very early appendicitis cases to treat them non-operatively, give them antibiotics, give them time to recover. This is still quite uncommon in the US, but we're starting to see it used in some of these cases that are extremely early with very subtle findings in a patient who clinically appears to be doing well.
So you mean your surgeons operated on the patients depends on physical findings or depends on your CT reports most of the time?
So usually they trust our CT report. Again, if they were that good at the clinical findings, then they wouldn't need CT so much, and we are much better than a physical exam for the diagnosis. But your point, I think, is their decision to operate is informed both by our report and by their exam. If they have a very healthy appearing patient who's doing well with very, very subtle CT findings, they will occasionally choose to treat these patients with antibiotics and follow-up, and won't take all of those patients to the OR.
Because on one of your slides, you show the wordings you use for your examinations. I think the second or the third is suspicious for early appendicitis.
Yes.
That is my concern, because nowadays you see some recurrent appendicitis because we use antibiotics.
Yeah.
And I don't know whether we can still use this diagnosis for most of our patients. Suspicious, I think this.
Yeah.
The third one.
This one here, I said highly suspicious. Here, to me, this means almost diagnostic of. You're right. I like to avoid uncertainty here. I don't like Birad's, Birad's 3 for the appendix. I want to go with either normal or abnormal. Occasionally, we're in this very early gray zone where the findings are so subtle. I will usually make my decision one way or the other and come down with it. So I will often say findings of mild, early, uncomplicated appendicitis. I think some of my more junior colleagues might not be quite as confident, having not seen thousands of cases. But yes, I think it's our job to be as definitive as we can here, so that the surgeons know how to manage these patients.
Can I ask you one more question?
Of course. Yeah.
Do you still believe that there is a diagnosis called early appendicitis? Do you still
yes.
agree with the CT findings, or you put this diagnosis because you know the onset of the symptoms or what? Because sometimes, like I asked you just now, the criteria for early appendicitis,
yes.
subtle does not mean anything for us to train a resident. This is what.
Well, so yes, I believe that there's early appendicitis, because at some point you go from not having appendicitis to having appendicitis, and at the beginning it's early. I think, to your point, we're probably not very good at looking at the CT and deciding when did the appendicitis start. And so that's a very good point. I didn't talk about chronic appendicitis. I think we're very bad at this diagnosis. But you can see some patients who have persistent wall thickening and very subtle inflammatory changes that could represent chronic appendicitis. I at least am not very good at distinguishing that from early, subtle, uncomplicated appendicitis. I'm not sure it matters. I think those patients should have their appendix removed. So yes, I believe there's early appendicitis. No, I'm not convinced we're extremely good at making that diagnosis. I guess early might be the wrong term here. I think more to the point might be mild appendicitis and uncomplicated appendicitis, because you're right, early implies that we know the time course, which we often cannot tell well from imaging.
What about the pathologists? Would they give pathology report?
They do not. They do not give us a time frame. Yeah. Okay, any other questions?
I will.
Okay, thank you. All right, now I move to the next one.
I think no.
One more, I think.
So we
Then I'm
proceed
okay.
to another topic.
Thank you.
Thank you very much.
So my next two talks are very much case-based. I'll have some questions on the final one. This is a little bit of a new format for me. I have very few word slides. They are all cases, and they are we stuck? We'll figure that out.